Very good, so that we can publish it in the CADQAS website. Okay, so thank you all for coming. I think I feel this is a really something I was looking forward, because we are forever doing training and doing proficiency testing on biomarkers that have been around for a very long time. You know, HER2 is a pain in the neck in my heart, because it's 25 years, 30 years, and we are still kind of fiddling with it. So it's kind of nice to say, finally, here are a few biomarkers that have never been really around before. And another one that is coming soon is the folate receptor biomarker. And if you have a little peek over the parapet on what the industry, the pharmaceutical industry, is doing, there are a lot of other biomarkers we never heard of that we will possibly soon be required to provide. Of course, Eleftherios was saying yes, if they have a pay for the drug, but all things considered, that's the way it is. Okay, so let's see if I can move forward. Okay, so this was an agenda, and as usual, Simona and I, just before coming online, realized that we have something like 150 slides to go through in an hour, so I think we'll cut short here and there. And it's difficult because this is a target that we haven't really heard before, so there are lots of things to be said. Nevertheless, we try. Very quickly going through epidemiology, it's a big problem, and it's an increasingly big problem. You know, if you compare Global Count 2020 to Global Count 2022, the gastro-esophageal cancer has come from fifth to fourth most diagnosed cancer, and from fourth to second most deadly cancer in the world. So this is an increasingly prevalent problem. Not sure why, but that's the way it is. And I gave you some figures here. You can have a look at it. But it's just to say that despite the fact that we don't diagnose too many of these cancers, you know, just to give you an idea, 15,000 in the UK. Compare this to breast cancer, we do 68,000 breast cancers. You know, so it's not very much. But almost all of them died. A few of them will be misdiagnoses. The pathologists like us, they say, oh, it's gastric cancer, and it's not. But some others are curable, etc. But very few are curable, essentially, even if it's not at an advanced stage of presentation. Hence, any drugs that potentially can buy something in terms of patient journey, etc. And then again, to tell you that this is not a cancer that you survive very happily. Not my number one choice if I had to get.
And unfortunately, yes, it gets diagnosed at very advanced stages.
Yeah. Okay. So this is a little diagram to say the usual spread will be liver. About 50%, lungs once it gets systemic circulation. So this is possibly through the portal circulation, then systemic circulation. It does go to the peritoneum, to the coelomic cavity, probably by direct spread. And then bone is another prevalent site at 30% present with bone metastasis. Okay, so classification. That's the WHO 2019. But before we talk about WHO, Lauren, this is the oldest classification I ever remember that is still pertinent. And he was a genius because he stumbled upon the observation that gastric cancer can be diffuse. And that was bad news. Diffuse is bad news. And diffuseness in those days was not really linked to any biochemical markers or any concept, but the concept of diffuse is the loss of cell-to-cell cohesion. You know, remember, epithelial tumors are trying to make structures that are trying to connect to each other, and these cells lose connection. And there is that concept in biology of tumor, the epithelial to mesenchymal transformation, which gives you a more aggressive phenotype. And we know in gastric cancer predominantly is due to loss of the cell adhesion complex, where beta-catenin and E-catenin have a part of it. In fact, some of the gastric cancer have got defect in ecadenic genes, that's familiar things, etc. A bit like lobular carcinoma of the breast.
Exactly.
Etc. So Lauren, fantastic guy. I'm in awe of this chap that made this observation. And then the WHO. WHO is kind of the usual thing. Let's keep dissecting tubular, papillary, whatever it is,
But still, even the WHO is still recognizing the Lauren classification. And even nowadays, in almost all our reports, we are saying the WHO classification of the morphology of the type of cancer that we're seeing, but also usually 80% of the times we're also putting the Lauren classification because it really helps the clinicians to have a better understanding. And usually when they are seeing the diffuse type, they know that that's more with a poor prognosis compared to the intestinal one.
Yeah. So cool, that's cool. These two are the most prominent type. In fact, adenocarcinoma is the most prominent type. Okay, so but now jump a little bit into this little heading here, molecular classification, because molecular classification has made, as usual, step forwards using those tissue collection from the Cancer Genome Atlas program, but also from the Asian Cancer Research Group, because gastric cancer in the eastern part of the world has got different drivers. And so those cancers are different. As a population, they're different.
And they behave differently as well.
So the Tumor Cancer Genome Atlas is a kind of Western world-based collection.
A little bit more.
And they did multiomics, and in more recent times, the multiomics is not just transcriptomics, but it's also obviously genomics, but it's also metabolomics, it's also to do with methylation. It's got a lot more information. And anyway, they came up with 5 groups, which are the EBV-driven tumors, the deficient mismatch repair tumors, the genomically stable, and the chromosomal instability. Differences in the nomenclature here and somehow of the composition of the groups. And then out of that work came a lot of effort that is usually always there for any tumor type to try and put this genomic classification where you spend a huge amount of resources to try to classify one case, obviously not popular, into something that can be managed when you have 200 patients a year.
Like we've done with the endometrial carcinoma. Exactly.
And so various people have tried various things. There is some disagreement, and us, among other people, have tried to do some work to trying to reconduce all this into a working classification. And the working classification is very similar to the working classification that is in endometrial carcinoma. It's a cascade system. First, you determine whether there is a sign of EBV infection, and these you don't need to do anything else. If it's positive, you identify this fabled group, a very small group of tumors that are very good, very good, and they are signature with EBV.
And usually they're also associated with PD-L1 positivity because it has an increased
immunogenicity. So so this is the EBV positive gastric cancer. Then you do mismatch repair. I think now most people perform these stainings, and then if you identify the deficient one, you can stop there. This is another category. If this is not deficient, proficient, you look for sign of epithelial to mesenchymal transformation. We use beta-catenin or ecadini. Other people use other things, but it's probably very accessible in immunohistochemistry to laboratory, in histopathology laboratory. If there is no sign of epithelial mesenchymal transformation, I know you are telling me you can actually eyeball the Lauren diffuse, but sometimes it's difficult.
Yes, sometimes it's even trickier.
Yeah. Then you do a P53, and the P53 is being used in other classifications to identify the chromosomal instability tumors, those that have mutations. And for this, we need to learn to identify mutant patterns versus wild type patterns. It's not positive or negative anymore, because also negative could be mutant pattern.
Indeed.
And then if all of these fail, you end up with a genomically stable groups. We identify also a category which is unclassified because there are always failures in all of these things. Run out of tissue, things don't work, things are cannot be interpreted very well. So we have 6 categories, and these are little pictures of tumors that have positive and negative, etc. So the reason for the molecular classification is because it gives you, and you can link it also with the Laurent type, you can link it to the prognostic in a way, but also the therapeutic options.
That's the most important.
Most important. So what are the therapeutic options for these people? Well, if deficient mismatch repair, second line can get pembrolizumab in second line. So there is a PD-1 route for that. Some tumors have PI3 kinase mutations, and although there is a small soluble inhibitor, this is not used in therapy.
The drug is available, but still it's not used. And also because it's a very small percentage of gastric cancers that they have this mutation. So
the big ones are the HER2 amplification. This has been established a long time ago with the TOGO trials, and they have access to trastuzumab plus chemotherapy or other therapy as well. And then in pale and now CLDN18.
Exactly.
And of course PD-L1. We've been doing PD-L1 using either the combined diagnostic for nivolumab with a cutoff of CPS5, or with pembrolizumab that had up and down. So used to be 10.
Now it's 1.
Now it's 1.
And now it's also another drug, tislelizumab.
Yep.
I hope so. With TAP now, the tumor area proportion that is, and it is done with another clone that we are using more in lung with SP263. So now we are going into even more, but that's for PD-L1.
Okay, that's right. Okay, and then in pale here, there are things that are either coming up, for instance, the fibroblast receptor factor 2B, or for instance, assessment of homologous DNA recombination defect for which PARP inhibitors and platinum are more effective. There are also specific mutation for which there are specific inhibitors, for instance, for HER2 or EGFR. Okay, so this is a classification that guide you a little bit towards what test to do next. Cool. Okay, enough of that. Let's skip that. Biomarkers for therapy selection. And we've spoke about it. HER2, mismatch repair, whether you do microsatellite instability or enzyme, PD-L1 and Claudin are kind of the 4 stable things.
If until now they were just those 3, now we also added the Claudin one.
Yeah. This happened before. I don't know how to get rid of it. Doesn't matter. Okay. Oh.
But someone, you have seen it was a name over there.
Just a moment. Let's see if
what
we
if
can
you can
delete rubber eraser. Yeah. Wow, fantastic.
Magic.
I've done it.
Lovely.
Okay, let's skip this because I'm conscious that we have a lot of things to talk about. That's what is Claudin-18 and where is it present?
Yes.
Okay, so it's a big molecule that spans membrane several times, and it's a family of molecules. So there are lots of proteins. Some of them are within the same type of Claudin, but they are isoforms of alternative splicing. So there are 27 so far described. And they have all these transmembrane domains, and then they have extracellular loops, and they interact with each other. And they are also, not exclusive, but they are also important constituents of tight junctions. So therefore are usually found in epithelial cells and provide cells with polarity, permeability or lack of permeability, etc., and they are expressed everywhere. Yes. But we're not interested in all the Claudins, but we're all interested in Claudin-18. Claudin-18 gene provides 2 molecules by alternative splicing. So there are slight differences at the beginning of the transcripts, and they are called Claudin-18.1 and Claudin-18.2. And the tissue distribution is slightly different. And what we will be interested in will be Claudin 18.2, but most of the antibodies, they cannot recognize.
Yeah, I think it's quite important to be aware of these, that there are two isoforms, and how we are going to say it's 18.1 that usually it is more in lung, and 18.2 that is usually more in gastric. The antibody it cannot differentiate. That's why the antibody is called Claudin 18. It cannot differentiate between the two isoforms.
Yeah.
However, the drug, the zolbetuximab, is linked to 18.2.
Yeah.
So they tried a little bit with in lung as well to see, but as we would have expected, we will have false positive, and then the drug is not going to function.
For positive in that, because it detects
18.1, yes.
Which is more prevalent in lung.
In lung, yes.
So although some non-small cell lung cancer do express 18.2.
Yes, but like this, we will not be able to differentiate indeed the responders and the non-responders properly.
Okay, so these are some slides to say that exactly what Simona said. 18.1 is predominant in lung epithelial cells and 18.2 in the GI tract, and it's not just in gastric. It's also present in pancreas, in the biliary tract, and also by any chance in ovary. Okay, so and this is kind of interesting for me because today we are going to talk about gastric, gastro-esophageal junction, adenocarcinoma, pancreatic cancer, biliary tract, non-small cell lung cancer. Some of them will be difficult to find out which ones.
Yes.
Mucinous adenocarcinoma of the ovary, the colitis-associated colorectal cancer, and
there are studies quite okay, not compared with the gastric. There are not that many, but there are studies for pancreatic and biliary tract, and again other claudins, Claudin 6, Claudin 5 with ovaries and other parts, but still Claudin family.
How does this become relevant to treat cancer? So normally you see these molecules are tightly packed in these tight junctions, and they are covered by lots of other accessory molecules, because tight junctions are supramolecular complexes. So normally, if you give an antibody in vivo, the antibody will not see it. It's really tight.
It's hidden.
It will see damaged tissue, but not healthy mucosa.
Indeed.
In gastric cancer, the complexes are not that well developed in some of the gastric cancer tumors, and therefore they will be accessible. And the drug, which is essentially a monoclonal, is a chimeric monoclonal antibody, will recognize it, bind to it, and that's how it affects its action. And usually the exposure of Claudin 18.2 is carried on also at the metastatic sites.
Yes, yes.
So you can say this word because I don't know.
Zolbetuximab.
Zolbetuximab. Okay. So this is the antibody. The drug is a chimeric antibody. So uses the mouse variable regions engineered with a human constant region. So essentially it's non-immunogenic for the immune system of humans, so you can give it to humans, but of course it has the antigen recognition specific. What we want is an IgG1, and that means he is very apt at mediating antibody-dependent cellular cytotoxicity and also complement-dependent.
Yes.
And this is possibly the major mechanism of action.
It triggers the cascade. Yes.
By stimulating the immune system. Okay, so the trials so far, or some of the trials so far, they could be relevant.
So it started with the FAST trial, and it has been a while ago, so more than 10 years ago. It was just for 2 years. It was a small trial only, but it was as a proof of concept to see if it is doable to make a bigger trial and to see if there is any improvement in what are we looking for the progression-free survival and the overall survival. And as a proof of concept, then
some good data.
Some good data.
So it may be relevant to say that, of course, they try to select patients and they use a particular threshold for positivity and a particular way of doing it, which will evolve because this is 2012 or something.
Yes,
will
so it
evolve
ended
during the years. Yeah.
2014.
So this was fast phase 2.
Yes, and then these are the main two trials how the drug got approved, and they both were simultaneously the GLOW and Spotlight. The main difference between these two, so they use the Ventana Claudin 18 antibody, and the cutoff was the same. The tumor cells more unequal than 75 with moderate and strong membrane staining. And they've done, there were two
arms.
Two arms, and one with placebo and the other one with the drug, and both of them associated with chemotherapy.
Yeah.
And now either had a different chemotherapy. GLOW was with CADQAS.
Yeah.
And both of them, they were randomized.
Randomized, yeah. And they were both of them, okay. So this is a common domain.
Both of them, they needed
negative,
HER2 because in the end, this was the problem. Because if it is HER2 positive, then we had other treatment.
And also it's also important to consider these are all first-line patients.
Yes.
First-line patients that are unresectable. So
unresectable or metastatic.
First-line patient, because if you wait for this to be in second line, the patient probably is not very fit for treatment.
Yeah.
So these are the patients you need to act on. And okay, forget about this. And this was the difference in placebo versus zolbetuximab. This is this progression-free survival?
The progression-free
survival. So how do you read these things? You take 50% and you say that these people get there in 7 months, but these people get there in 8 months. It's not a huge
huge amount.
Okay. So there is some benefit.
It is some benefit indeed. But and this is the overall survivor.
This is OS. Okay.
This is OS. And
we do this is progression-free.
This is progression-free.
Yes.
Yeah.
And as you can see, progression-free has got
2 months. You have 35 versus 19.
So they're reading at 12
months. Yes. They were reading at 2 months. Okay. And then Spotlight, where they used different chemotherapy, FOLFOX6.
Yeah.
However, and in the same settings of HER2 negative.
Yeah.
This one, however, it was a little bit more controversial, if I remember correctly, because they didn't expect for the control arm to do that well.
Okay.
Compared to the.
So this is progression-free and this is overall survival, but still there is
improvement. Still improvement on both of them. Still improvement.
Okay.
Good improvement.
So these are the figures of this trial. There are relatively small trials in any case, but interestingly, this seems to be a dumbing
the
stabilization effect rather than a curative intent, isn't it? So that's the
and both trials, this is what they highlighted, that they did not see a tumor shrinkage, but they've seen the disease to be more stable.
Right. Okay. So, and this is the one you selected.
This is the one because both trials, when they were conducted, anti-PD-1 wasn't approved. So nivolumab wasn't approved in those countries. And now they are doing the Illustro study where they are adding zolbetuximab and nivolumab and chemotherapy in first line.
In a way, it makes sense. So you have an anti-PD-1, so you try to stimulate the cellular mediated immune response, and then you give something that would stimulate cell mediated immune response as well by identifying the target. So
the data, it's promising, but it's still.
So this was one trial that Simona picked up for you to say this is potentially what's going to happen in the future. Okay, so immunohistochemistry, we are kind of almost in good time. So what is the immunohistochemistry of Claudin-18, which is why we are here in reality? So we just to summarize, we have an antibody that will not distinguish between, and actually, to be honest, no antibodies at the moment that we know of distinguish between these two isoforms.
No. It's the only one.
So when it's positive for either of them. And there are other clones and other antibodies that you can see here in this table, including a polyclonal antibody. Astella has conducted a global ring study and showed that most antibodies are equivalent in some shape or form, but you need to read the small print because equivalence is better than 85%. Concordance, that's 15% discordance. That's a bit big, but however, these are acceptable criteria. But the polyclonal antibody didn't really live up to that. But importantly, for this, for our information, is that the Ventana clone, that is the clone that has been used in those other trials, and therefore it has now the companion diagnostic label at the moment. You can stain it with other platform, like in the DACO platform or the Leica platform, and that has always been the problem for all of us because some of us don't have Ventana, and then therefore what do we do? But actually the staining characteristics are very
similar.
So you can work.
On the Ventana is more sharp and it's more clean, but it's not a huge problem.
Yeah, probably you will end up identifying most of the same cases using other platforms. The same antibody, but different platforms. Okay, so forget about this, and it's just to tell you. We talk about this, yes.
That takes the both isoforms.
Okay, so how do we interpret this,
Everyone is
okay, so there is this great booklet, which is the interpretation guide, which I think will be on our website and can be downloaded if you cannot find it in other forms. So 6 steps. The cell type has to be invasive carcinoma, only invasive carcinoma.
Yes.
The positivity has to be more or equal 75% of tumor cells, of invasive tumor cells. The subcellular localization is membrane staining. We need membrane staining. Cytoplasmic staining, not scored. It can be there, but you don't score it. And you shouldn't have nuclear localization, but nevertheless. The type of membrane staining is any, as in linear, complete, circumferential, granular, etc., incomplete, luminal, whatever it is, it's all acceptable. A little bit rather than all of it, it counts as positive. The staining intensity, that's more interesting, is only strong and moderate staining intensity, not weak. Weak doesn't count as positive. And then for the 6th point, how to recognize the staining intensity, one would say we use the magnification rule. But in fact, it's about chocolate.
It's always about chocolate.
But that's why I like this clone. Okay. So that's what they introduce. So they tell us that dark chocolate is very good.
Yes.
And milk chocolate is acceptable, but this fudge is not staining. Okay. But then interesting, these are some kind of examples. So this is milk, this is very strong, and this is very, very weak fudge, they call it. Or very light chocolate. But also they also put pluses. Yeah, they say 3+, 2+, 1+, and then you kind of scratch and say, well, how do we recognize it? Times 5, times 10. The magnification rules come alive again. So if you read the interpretation booklets, or if you also go to other courses where they teach you interpretation and they say it's all about chocolate, don't worry about it, because the magnification rule is still very important. Yeah.
But I think we need to make sure that it's membrane. So even if you see something at ×5 and you think, oh, this is my dark chocolate, it's beautiful, make sure that that's membrane. Always try and put a higher power. It's membrane, then it's fine. We've seen it from ×5. Cool. So it's strong.
Okay, so then in a resection specimen, and I will tell you this will be the easiest one to interpret because our pain of life is this little endoscopic biopsy that may or may not have invasive carcinoma or dysplasia, and God knows what we are looking at. In the gastric resections, you will find that there is the normal or hyperplastic, it doesn't matter, the non-neoplastic mucosa staying strongly. Then you will find that perhaps some metaplastic mucosa is weak staining. And then you'll find that tumor may have different staining intensity. This particular area here is weak and moderate, and some of it is strong. So there may be different staining intensity. And remember that in order to get a 75% positivity of overall to all the tumor cells, we cannot count the weak ones, only the moderate and the strong.
And the strong one.
Okay, so we said circumferential, partial, complete, basolateral, lateral, granular, those beaten string that we spoke about with HER2, apical, or what they now call it microluminal. So inside the little rudimentary lumina that some of these cells make is also.
But make sure it's membrane still.
But make sure it's in membrane. So the major difficulty or potential pitfall is that because the cytoplasm also stains, you get a little bit distracted and you say, oh, it looks positive because I can see the staining, but actually the membrane staining is weak and therefore you should.
The magnification rule is helpful, but we need to keep this in mind compared with other, compare with HER2.
HER2 is a much more simple assessment. We can do a low power. Okay, here is some examples of these, perhaps microluminal or an apical staining patterns, etc., etc. And here is some examples of cells that also have cytoplasmic staining, and therefore it's all a bit confused, or where the mucinous material stains, and so also you get a bit
still confused. Here you have some membrane a little bit.
I don't know, that looks like to me like a necrotic, I don't know, a blob.
Maybe.
I have no idea what
here.
we're looking
but
maybe some.
This one you have granular, just granules like precipitation wise.
So you need to be a bit more discerning when you look at these pictures, and also be careful because as usual with most antibody necrotic tissue stains, so you may have, look, it's really brown everywhere, but and also do you see how nice membrane staining there is in necrosis? Okay, fine. And here is to say something else. So yes, this is to remind us that that staining pattern that we discovered more recently in breast, this basement membrane-like pattern, you can see also here. So the basement membrane stains, but there's not membrane staining because basement membrane is really an extracellular matrix. Okay, so distinguish that from membrane staining of the tumor cells. Okay, so some more, examples you see here. That's the dysplastic epithelium cannot be scored. This may be probably normal tissue, normal mucosa cannot be scored. So you need to find the invasive carcinoma and then try to identify whether it stains or not. Again, if it's present, use the normal epithelium because it's your reference strong staining. But they say if you don't have it in your biopsy, then use the magnification rule. Use the time 5 and then you find.
And theoretically, you should have an on-slide control, theoretically, and then you can compare with that one and form your eye in that moment and see
but
the intensity.
You can also see why they are talking about dark chocolate and light chocolate, etc. There is this.
This more dark, more
Okay. So again, you can use the magnification rule, but make sure that this is specific membrane staining and not cytoplasmic. And of course, you see here some example of weak staining that you cannot count towards the tumor cell positivity. Fantastic. So just as an example, this biopsy 0% because this is normal in dysplastic mucosa, and this biopsy, most of the invasive carcinoma stains at least with moderate staining intensity, and you can say it's above threshold. Okay, so just as a summary, understand the denominator, and that's probably quite important because sometimes the invasive carcinoma cells are dispersed in fibroblastic tissue, and you don't really realize how many
there are. Especially the signaturing, the diffuse one, not necessarily the
So you have to have a good grasp on how many invasive tumor cells there are, exclude dysplasia.
Oof. Yes.
And that's
a little bit more
sometimes.
difficult, especially on small biopsies.
Obviously, exclude tumor cells that are necrotic or non-viable when the tissue was fixed, because that can contain artifacts of staining. And then when you assess it, make sure that you assess only the 2+ and 3+, and it needs to be membrane, any membrane, but any type, even tiny bit, as long as you feel it is located in the membrane. So even these beads on string type of thing. Exclude, obviously, polyprocessed cells, the basement membrane staining, the cytoplasmic staining, and the granular staining that is not membrane bound. And also be careful, because mucin will also stain. Okay, so that's good. Very briefly, because Simona's prepared some case studies, which I think would be much more interesting to discuss. Very briefly, let's talk about quality control. Not my best subject of conversation, especially because we start with a non-specific staining in negative reagent control, which is, as you know, my position to it is an inheritance from the far past. We should be stopped talking about IG negative reagent control. However, I understand that some of you are very fond of it, or are being forced by terrorist organizations to waste one position of the immunostainer for the negative reagent control. But let's keep the non-specific staining. I think we are all experienced pathologists. We understand non-specific staining. Do have on slide either the endogenous positive control of the endogenous of the tissue, or you put in it a little piece of tissue that you know it stains well. Normal mucosa is great. If you also have mucosa with metaplastic tissue, will give you that weaker staining, which is very important for your controls. Okay, and then have a look at background staining, and here it's just giving you some suggestion to say vessels should not stain, connective tissue should not stain, muscles should not stain. Okay, these are all normal things we know.
Just a little bit of a heads up, especially here when they are saying strong membrane in the normal gastric epithelium, weak to moderate in metaplastic. Some metaplastic glands do not have the colonic, the intestinal metaplastic, where you see very nice the goblet and everything. They don't have that. So then those areas, they are going to stain weak to moderate. So don't disregard them thinking that there's normal epithelium, normal gastric epithelium, and it's not staining strong. So that's a little bit of a pitfall sometimes.
Yeah, interesting. Okay, so we're really good, because we have 20 minutes, 15 minutes for case studies, and then some question and answer and a discussion. Okay, so Simona's prepared 5 cases. So the first one is not a case. It's
first one, it is a case, but it's a case very low power, because what I wanted to show here is that how we have here the biopsy, our tissue that we need to interpret with the Claudin. So this is a Claudin IHC. And here we are putting the on-slide control, which is a normal gastric mucosa. So like this, our slides look like. Yes. And now here it's more in detail, a little bit of zoom in, not hugely. I always say, whenever we are interpreting any biomarker, a low power, and it gives you a feeling. If it's all negative, either something didn't work, but if you have the on-slide control, then we are happy, or it's completely negative. And here we can see some staining, some blackness. And now I always say, then you put higher power to see what is there.
To me, this looks like a gastro-esophageal junction. This is squamous epithelium, and there is something.
Need high power.
I already made a diagnosis. Very good. I'm very happy today. And so this could be an adenocarcinoma GEJ junction, but this is negative.
Well,
there is something positive here. Is this tumor?
Well,
we have a higher
power. I took a little bit of higher power. Okay. So these are the areas more like papilla a little bit. It is an adenocarcinoma where we can see there are some weak that we can barely see. So we should not this one will be weak.
Yeah.
And then
this is a milk chocolate.
That's milk chocolate. That's already a 2+, maybe a 3+, a few cells, right?
But this is not 75%.
But it's not 75.
There are a lot of cells that are not staining.
And that was.
Is there a higher power?
Yes. Well, it's another area.
Uh-huh.
This is a different area
Yeah.
where again it's invasive carcinoma. And again, even if you have some staining here, it's more weak staining. And
Yeah.
you don't even need a higher power for this. You're already times 10.
Yeah.
And you can barely see some very fine.
Yeah.
Now, even if it is membrane and it's not cytoplasmic, it will go into the weak category. So it's
So it doesn't
non-scorable.
count.
So then if we are going here, this
Yeah.
is the bit, the last one that I showed it to you, and this is the first bit. So this you could make it positive, this will be moderate to strong, but still your tumor would have been all of these, all of these, all of these, here a little bit, here a little bit, and here a little bit.
Okay, so
and these bits are almost
we are
nothing.
10, 15, 20%, or something like
Yes,
this. Not a lot. Okay. So in a way, this was quite easy to identify because the adenocarcinoma doesn't look as if it could be dysplasia. It's
No.
just invasive here.
Yes.
Yeah. But my fears are where we have this small biopsies.
also that.
Oh, we have some of this. Okay.
We have some.
Let's go.
Those.
Case 2.
Case 2.
Oh, this is a diffuse carcinoma.
This
here.
is the diffuse carcinoma. This is one of the main. This is one of the main subtypes why it is the zolbetuximab is very useful because the diffuse one are more aggressive. Usually they are occurring more to younger people, and we need treatment, especially if they are HER2 positive, PD-L1 negative. Right now on the market,
HER2 negative.
did I say positive?
Yeah.
I'm sorry. HER2 negative,
Yeah.
PD-L1 negative. So then our only possibility to treat, intention to treat is zolbetuximab with claudin.
Yeah. Okay, so this looks promising. There's a lot of staining at very low power. We are at times 5.
Right.
So maybe 1 or 2 of these things are strong, but maybe if this is membrane staining, maybe there will be moderate staining.
Next step, we need to make sure that this membrane staining, for sure, and how many cells are with moderate and strong.
Okay, so how many cells are kind of here? There are gaps. I kind of feel that maybe 80% of the cells have some staining, if we can confirm that this is, but some of them are too weak.
Some of them, they are too weak.
I fear that this is not going to be above
It was above 75, but it was an 80%, yes.
80%. Is there a higher power?
I don't think on this case, no.
Because I wanted to see whether these were really.
But you said here times 20.
Okay, but you see, I have some uncertainty about some of these brown things.
Indeed, even if they will be positive, they will be weak already. If you're putting times 40 to confirm that you have a membrane staining over there.
Can I ask you something? This is not 80% here. Maybe it was 80% throughout the biopsy.
Even if you're looking at all of these.
Yeah.
Here, I think it was not a tumor. I don't remember exactly, but here you can see how it infiltrates everything. Okay. So almost all the tumor was staining. Now the question was the intensity.
Yeah. So that's the difficulty. Okay.
Yes.
Okay. So case 3.
Case 3. Yes.
This is very promising.
Very promising.
Well, I don't know actually, because this is all mucosa.
That's the
problem. This is
problem.
I was hit by staining, but
don't jump.
That's the
This is one of the IHC stains that even if you see dark, our beautiful dark chocolate, that doesn't mean those are tumor cells.
Okay, so this looks possibly is invasive tumor here.
We will have a higher power for this.
Okay, yes.
This
is invasive.
So this is invasive, but look.
Not good.
And I think
25,
we have
30%.
even a higher power where you can see these are your tumor cells, this is your normal mucosa, and this is staining, even quite strong. This is barely, some of them strong, but some of them negative.
So in order for me to interpret these things well, I need to learn gastric pathology. I cannot just read the slides like this.
And as you can see here, all of this fragment almost inside, under the epithelium, it's invasive carcinoma here. And you have gaps here. You have gaps that are not even staining and in between. So this one was way below the threshold.
Okay, so this negative, unfortunately.
Negative.
Okay.
But have you seen how promising was from low power?
Very. I thought, I found a super positive
and
case.
If you're going here, except this one and a little bit here, these were without any carcinoma. And they're still staining because you have the normal mucosa.
Okay, so we need to apply ourselves to this. Okay.
Two.
Do we have another case?
Yes.
Case 4. Very good. Ooh. And now this is normal. Now I know.
Now you know.
If he's strong, and looks tidy, this is normal.
This is normal.
And this is nothing.
Unfortunately, I
we
don't
don't
have
even
full here, but
we don't even have to see high power.
this is your normal, which is
Yeah.
not that normal. See,
No,
it's
a bit
tiny,
back in place.
this plastic,
Yeah, but not invasive.
but not invasive.
Unlikely. But I find it really difficult to make sure it's not invasive.
But then that's true. But then this is your invasive.
This is the invasive carcinoma. This is diffuse.
This is this fragment here that I pictured. Yeah. So is this one here on the next slide that is here, and this one with this one here is this one.
This one. And do you think this is a polydifferentiated or is it diffuse?
That's a very good question.
Because it could be still cohesive. I'm not sure.
I don't remember. I can have a double look, and on the next meeting, I can tell you if this one was Icadarian and beta, because we do have all the data on it.
Okay, so case 5.
Yes, case 5.
Okay, this case, okay. So normal mucosa, foveolar things, and then this is all normal. The dark staining is normal. I don't know what's in here. This is this fragment here, not stained. But this is again normal mucosa. Here, this looks suspicious to me.
Yes, those are heavy on
this
looks
also suspicious carcinoma. So possibly negative. And what about this one? This could be tumor.
That one I didn't. You will see.
Okay.
It's not because, and I will show it to you.
So these two first?
These two first.
Yeah, invasive carcinoma here.
Yes.
Diffuse, probably diffuse.
I think this is more poorly differentiated, because if you're seeing here at some point you have clusters, and then they are just.
Yeah, so poorly differentiated.
Yes.
And it's completely negative, this area.
The only reason why I took this one, it's identical with the one below.
Yeah.
Because it's better, you'll see, it's better.
Okay, so here.
And now,
well, this
question is, what are these here? And these are this. And it's identical with the other one.
So, and it could be that this patient has got 2 different diseases, are more aggressive, more differentiated.
Or it could be this, that is high-grade dysplasia, compared to, again, this is your invasive carcinoma.
So what happens when we find 2 different tumors?
Yes.
In the same biopsy? One is polydifferentiated, one is well differentiated, one is positive, one is negative. How do we report that?
Well, I think the same how we report her too. Heterogeneity.
They say there are 2
and
tumors here.
If we will have an excision specimen, then of course retest on excision specimen and see. But if it's not just to treat, it's up to the oncologist, how much, the percentage.
Okay, is there another case?
I don't think so. I think we're at 5.
We're at 5. Okay, we're on Q&A.
We have time.
So Q&A, we could stop sharing then. Fantastic. And we can open discussion, if there is any discussion. I don't know. How do I unpin it? Remove pin.
Da.
Fantastic. Okay, so this is a little kind of very fast workshop to give you a little bit of direction in interpreting the circulation, provisional intestine circulation that Sarah will open.
It was open.
It's already open. Oh, it's already open. And then, so just for you to navigate the slide, so you have a little bit of a feel on how to.
There are more tricky cases, I think.
How to handle this biopsy.
On our proficiency testing, they're a little bit more tricky.
They're a little bit tricky.
A little bit.
Okay, don't worry about it. The problem is that nobody asked me anything anymore. So I would have chosen much easier cases for you so that everybody goes home happy and say, oh, look, this is really easy. But instead, they hit you hard with very difficult cases. Okay, that's fine. Don't worry about it. I think that we are grateful to Estella's for sponsoring this circulation, and Estella wanted to have an understanding on how good or how bad, how good we are in distinguishing those tumors that are clearly negative, let's say 0, 10% or 20%, from those tumors that are clearly positive, like 90 plus, etc., to those tumors that sit a little bit in the penumbra around the 70, 75%, 80%, which may provide a little bit more challenge. So Sarah has asked you in this circulation to put the tumors in bins, in percentage bins. I can't remember exactly what the percentage bins are. So don't be worried about it, because this is not really a reporting being category like the PD-L1, etc. But it's just to have a very early understanding on how people assess these things, etc., etc.
We have some questions.
Very good. You can read.
First one, difficult interpretation of cases with negative and positive areas.
Yeah.
Yes. Intensity and percentage of positive cells are reported. I think this is a question that also, do we have to mention in the report the exact percentage of the staining?
No, I don't think so. So this is the problem, now here it is a test that has this complication. This is how we need to interpret. Now, if you leave it in the hands of extremely scientific trial pathologist, open bracket, Beppe Viali, etc., close brackets, they will tell you, we want to know exactly how many there are 1+, how many there are 2+, etc., etc. So Beppe, it will take us half a day to do this, yeah, but this is very important. But in reality, it's not, we need to have a positive or negative. If you can help Sarah by giving an understanding on how much there is, that's helpful.
Exactly.
Because you also help us understanding what are the real difficulties.
Because even with the same, I would say, with PD-L1 and other markers that you need to give a percentage over there, and not just percentage, because CPS is not a percentage, but regardless, it's one thing to be over there at the threshold and to say, okay, on balance, I ask 3 of my colleagues and I'm making it just about the threshold. So then you have a question, is this patient going to actually respond to the drug or not? And another thing is like, wow, everything is positive, 100%.
And also there will be very little controversy about anybody looking at a case like this and saying it's really positive. So no, we don't have to report every single pluses and 3+ and 2+.
But I think it will be useful to say positive, negative, in brackets, give a percentage.
Yeah.
Kind of, roughly percentage. But I wouldn't go into how many percentage strong, how many moderate, not quite.
We are told positive cells are moderate and strong.
Yes,
that's it, lumped together.
Is there any difference in response to zolbetuximab depending on the level of expression? Not quite.
Not that we know of.
No, it's the same as, okay, if you're saying 75, maybe it wasn't 75, it was a 73. So maybe it wasn't that eligible and it's not going to respond. But otherwise, it doesn't mean that a person with 75 and is going to respond less than a person with 100.
I have to say, we have very, very little kind of information about these things.
The papers.
Whatever it kind of is published at the moment. And so hopefully, and the reason why I'm kind of excited also about this thing is because Stella has been really nice and has been collaborating with us. So we're bringing up this test for you. And then also there will be some more discussions so that we can be a little bit more educated about these matters and perhaps can bring the answers to you as well.
Another question, maybe I missed, but how many tumor cells do we need for lecture? To count, it's 50.
So just a moment. Somebody picked up a number from the head. This is 50. Okay. If it's 50, let me tell you, if 50 is Roche, if it's DACO, is 100.
Okay.
There is no evidence whatsoever behind
it. To be impartial, I would say if it's 50, and if it's negative, then you can say it's negative. If it's less than 50 and it's negative, you don't have any staining. That, from my point of view, it will be indeterminate.
Yes.
If it's less than 50, but it's positive, I mean, those cells are clearly positive, then it will be, I wouldn't call it necessarily positive, but it will be a comment. Please note that the sample it's quite not suboptimal, but there are a few tumor cells, but they are positive.
But my kind of comment was regarding the fact that there have been some studies, for instance, ALK. We know that ALK, one positive cell, treatment, and there is evidence of response, one, okay? But there is no data whatsoever about all these biomarkers when people say you need 50 or 100 cells. It's just picked up from the hat and say, that's what we do. Okay, that's fine. But I mean, usually if you have very few cells, you kind of feel...
you don't feel that comfortable. That's what I'm saying. But if they are positive, then yes.
Yeah.
With a comment.
So it's another question. Protocol to report. By mean was, you mean in which way you worded the report? I think you need to say you did Claudin 18 using what test you use, because you may want to use a different test, you know, and then you want to say that the scoring, you know,
the scoring algorithm that is.
Well, the scoring algorithm is the prescribed one for this indication, and it may be that Claudin 18 will become a biomarker for other drugs, and it may be that the scoring algorithm for other drugs will be different. Who knows? But at the moment, there is just one.
This is done only for gastric adenocarcinomas. Is it done on mets?
So it's for gastric and gastro-esophageal junction adenocarcinoma. Obviously, we are in the hands of the gastroenterologist to know is gastro-esophageal junction and it's not.
We did have esophageal sent with the request of Claudin. We performed Claudin, but of course it was a comment. Please, if this is primary esophageal, then it's not eligible for. But if it's gastroesophageal junction, then it is eligible for. So
at the moment, yes, it's just for gastric. Yep.
It's another.
Liliana says, well, but let's cut a lot of sections and then add them all up. Well, yeah, maybe. Who knows? I think, Liliana, if we have so few cells in a patient, you know, it may be reasonable to say you really need more material. I don't know. It's kind of...
I do believe if they were positive, then maybe...
Yeah, maybe you can say that.
Then yes. Yeah. But if they are negative, I think it's a little bit risky to call it a negative when we have less than 50 on a slide, even if we are cutting levels.
Yeah, especially when Roche says we need at least 50 cells. So kind of, you could say, kind of, it's not recommended.
Yeah. Yes. Just indeterminate, and please repeat on other biopsies or excisions if available.
Very good. So please do unmute yourself and make any comment if you wish to. You know, I know this is kind of workshop and Simona and I are telling you what to do, but it's not intended to. And if you really, I think it would be great to hear from you your own comments about all these things and your experience as well. But I'm really pleased that we did on time. I wasn't expecting it.
Fast forward a little bit. But Vienna.
Vienna, we are having a
Congress of Pathology. We are hoping that we are going to see you there.
On Tuesday, the 9th of September. We will be delighted to offer you cocktails or other
presentation. And we are offering you cocktails. And the presentation, it's a bonus. Now, if you want to hear more about Claudin.
What would be a presentation like this one, or will it be just a feedback?
I think it will be 2 in 1.
We look at cases. Okay.
It will be.
And
it is a master
class. It will be like we did last time in Florence, in a hotel very, very close to the venue. So
people can
200 yards, so you can come over. Will be around about 7 o'clock.
5 o'clock.
5 o'clock. Oh, from
we
5,
have Sarah
5 to
here,
7.
She's helping us.
5 to 7. We'll drink. We'll have a nice drink together, and then we'll talk about some staining here and there,
and some chocolate.
And some chocolates. Very good. And we need to have chocolates with the cocktails then.
Yes, with the Claudin.
Yeah. Okay. Very good. So thank you. Hope I'll see you in Vienna. Those of you that are coming.
Yes. Thank you very much.
Thank you.